Welcome back to the Modern Metabolic Health Podcast. Today I have Lisa Tritto, Dr. Lisa Tritto. She is a board certified pediatrician and obesity medicine specialist who I met during an obesity mastermind for doctors who are going into the field of obesity medicine. And she is a true treat here today because she is one of the very few fellowship trained pediatric obesity medicine specialist. She is passionate about changing the way we understand and treat pediatric weight and metabolic health. She takes a compassionate, science-driven approach, helping families move beyond outdated, eat less, move more messaging to better understand the roles of biology, behavior, and mental health. She offers an individualized care that may include nutrition, lifestyle support, and modern medical therapies, including anti-obesity medications when appropriate. Her practice is called Evora for Kids, which is based in St. Louis, Missouri, but she's licensed in many other states and will see patients throughout in some states throughout the country. So thank you so much, Dr. Tritto, for being here. I'm so happy to have you.
Yeah, thanks. I'm very excited to talk about my favorite subject, and it's nice seeing you again as well.
Yeah. And right before we jumped on, I was curious, so I Googled how many fellowships for pediatric or pediatric obesity medicine fellowships there are, and I only saw that there's two. Is that right?
That's about right. Yes. Yeah. So I feel like I know everybody who's been through the fellowships because it was basically all the people who preceded me. So they're just a handful of us in the country.
Yeah. So again, so fortunate to have you here. Thank you for taking the time.
Yeah.
Um, well, actually, before we get started, I would just love to hear what prompted you to get into this specialty.
Sure. So many reasons. I struggled with weight myself as a teenager and adult. Family members also the same, and um, also my patients. So, I always knew that there was more to it than, you know, eating less, moving more, as people tend to say, because I was doing all the right things, and I thought I was doing all the right things for my family, and I was telling my patients the things, and it didn't work, and it didn't add up. And so, after being in general pediatrics for well over 20 years, I had an opportunity to shift gears in my career, and so I chose to go do this um, year training program, and I'm so glad that I did, because really the science that I learned in medical school has changed. In fact, we didn't learn any science about weight management and metabolism in that regard in medical school. And it's been so fascinating to learn about it and now to be able to apply it. So that's sort of how I got there. And I really wanted also a shift from the pace of general pediatrics to being in a specialty situation where I can spend a lot of time with my patients and really help them get to whatever their individual needs are.
Yeah. Yeah. Well, how should parents and clinicians think about pediatric obesity today, and what have we gotten wrong in the past or continue to still get wrong about pediatric obesity?
Yeah, just with same as with adult obesity, that we know now that it is really a disease process, that there's biological, biochemical processes going on in the body that we can't see. And um, it is, what am I trying to say? Uh, it's It's very complicated. So there are so many factors. There are mental health factors. We now live in an environment where, as I tell my patients all the time, it's not your fault that food is everywhere and food is delicious, and we don't have to move our bodies like we used to. So if you are sort of predisposed biologically to have that sort of environment affect your weight, then you're going to carry extra weight. And some people can live in that environment, but they don't have that biological predisposition. And that's why, one patient looks completely different than their friend, and they seemingly have the same lifestyle.
Mhm. Yeah, there
Yeah.
are so many factors, um, and obesity, as we know, is a chronic medical condition, multifactorial condition. And what I think is unique and what I find difficult, I'm family medicine trained, so I helped kids and adults. But what was always so difficult with kids is, they don't have full control over their choices because the parents are usually the ones, doing the grocery shopping and, helping with ordering when out and that sort of thing. So it adds even another layer of complexity to pediatric obesity care versus adult obesity care.
Right, right. Yeah, it's definitely, it's a family approach.
Mhm.
It's certainly not directed all at the child. That's for sure because yeah, they need our help. So
Yeah.
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 And this is the kind of a tangent there, but for your appointments, who is at the appointments for your pediatric patients?
It will be the patient and at least one parent usually, one or both. I have the parent fill out a very lengthy questionnaire before I see them, so I get a real good feel of what their home environment is like, what their perceptions of what's going on with the child and what their goals are. And then if I have a adolescent patient, then I also have them fill out their own questionnaire privately so we can look for things like eating disorders and how is their weight affecting their sort of mental health. Um, so yeah, so it's it's both together, and then usually I have a little bit of time individualized with the patient too. That's sort of how our first visits tend to go.
Yeah, great. Yeah, that history is so important. And that was one of my questions was the link between mental health and weight, and specifically ADHD. Can you tell a little bit about your experience in your practice with that connection and what science and studies are saying about that?
Sure. Yeah, I see a lot of ADHD in my practice, particularly when I see a younger patient, maybe somebody who's maybe 8 years old. A lot of times they've had sort of undiagnosed ADHD. And as a general pediatric background, I'm very comfortable with evaluating and diagnosing with ADHD. So I find myself at times ending up doing a kind of a workup for ADHD at the same time. And then I find that when we treat the ADHD, some of the eating behaviors do improve. Um, the with ADHD, these kids tend to have eating for many reasons other than hunger. So there's impulsivity around eating. There's boredom eating. There is um, um, problems with sleep with kids with ADHD, and problems with sleep can lead to overeating. And we do, the science shows that if you have obesity, you have a higher risk of having ADHD. If you have ADHD, you have a higher risk of having obesity. And we know that a lot of these circuits in the brain are similar or overlapped with our what we know about obesity and ADHD. So there's a sort of this um, pleasure seeking, dopamine seeking nature of those with ADHD.
Mhm. Yeah,
Yeah.
so fascinating. Um, And we're going to talk about GLP-1 medications and their role in management of pediatric obesity. But before we get to that, I'd also like to hear some other medical conditions that you see your patients for that may be weight related or some other things that you help your patients with.
Yeah, I will see kids with signs of insulin resistance, which we know is part of that metabolic syndrome. And sometimes it's when they're younger, it can be just something that I find on their physical exam, like there's a particular rash behind the neck that can indicate that they are having blood sugar issues. The way I explain it to my patients is I say, this is a sign that your body is working really hard to keep your blood sugar normal. So I see that's sort of on the early end spectrum of insulin resistance. And then I will treat kids that have prediabetes. I can diagnose diabetes. I don't manage diabetes. I often see fatty liver disease related to weight. Um, and that can show up in different ways. Uh, Not uncommonly, especially during my fellowship training, we would have a referral of a patient who is carrying extra weight and had some sort of abdominal imaging for some other reason, and they found that the child has a fatty liver. So before their labs have even changed, um, they are starting to develop signs of, metabolic dysfunction. So I would see that, and I can manage that up to a certain level. And then, so they don't all need to go see a gastroenterologist first. They can see me and I can manage most of it unless their levels are very high. Um, we'll evaluate for other conditions related to weight, like sleep apnea, um, and then anxiety, depression, and also go along with that as well. Autism is another medical condition. I don't manage it specifically, but it often is co-occurring in patients as well. That increases their risk of obesity.
Mhm. Yeah. And so that highlights how much you're pulling in, not only from your fellowship training in pediatric obesity, but also just your general pediatric experience as well.
Right.
So that's
Yeah.
wonderful that you have that solid baseline.
Yeah. Yeah. It is really good. Yeah.
Um, So, like I said, I want to talk about our anti-obesity medications or obesity management medications. Most popular right now, Wegovy and Zepbound. What, from a pediatric obesity physician perspective, what is your approach for using these medications? And again, what do the studies show with these medications?
My approach is first sort of that getting that big medical history and personal history, family history, social history, all of this. Um, and then deciding together with a family if they, I should back up, I would explain all the factors going into their child's particular situation. And then we would decide together if they're interested in medication. Once they sort of understand the underlying, you know, pathophysiology, they can understand how medication will work for their child and that it's not taking an easy way out, or it's not cheating and somehow. Then, to decide, does a child need medication? Do they qualify for medication? It depends. If we still use BMI for kids to determine whether they have obesity or not, but also in my office we do body composition as well. So I could have somebody who's sort of borderline on weight, but they carry a lot of body fat and not a lot of muscle. We could qualify them as having obesity too. So it depends. So it's a joint decision. If a child's weight is sort of, I would say, kind of not that bad, and they want to work on lifestyle stuff first, we absolutely will do that. If somebody comes in, they're really carrying a lot of extra weight, they already have signs that their body is not functioning well, like abnormalities on their labs, um, then we'll start medication right away. And then always working with diet and activity and all the other factors that are going into their weight. That happens for everybody, whether they're on medication or not. Um, and I do use the GLP-1 medications, usually in kids that are 12 and above. So Wegovy is the only one that's approved for 12 to 17 as far as the GLP-1s go. And then Zepbound if I'm seeing an 18-year-old or over. And I do see kids in through college. So I do use Zepbound with them a fair amount. And then there's another medication that most people have never heard of, Qsymia, which is combination phentermine and topiramate. And that's a pill, and it's much less expensive and it's much more accessible. And I've had patients do really well with that. I've had some that just need a very small dose, and that's just enough to help them um, start making some changes in their diet. And I've had one patient who lost 100 pounds taking that medication, and I've always told her, "You are my example. I'm going to tell everybody about it." I know this is how well this medication can work for the right person. So yeah, so we go over sort of all those options and decide like what makes the most sense for their child, or if one doesn't seem to be the right fit, then we, pick a different one as well. So yeah.
Yeah, thank you for bringing up Qsymia. I agree. Sometimes we forget our other medication options, and that can be a reason why seeing an obesity medicine specialist can be so beneficial, because there are multiple medication options, and some are less expensive than others, or just fit better for that person for one reason or another. And so having somebody who's familiar with all the options available can really make a difference. And for, like you said, for pediatrics, there's different FDA, I guess, indications, limitations, and depending on the person, I know sometimes medications are used off-label and, all populations. And so, of course, you're talking about risk and benefit with all of your patients there. I guess thinking about medications for obesity from, like a thinking about like a from a philosophy standpoint, what are some of the things that you like to emphasize when you're considering a medication or starting a medication? And I'm thinking first thing that comes to mind is like duration of treatment. Like, what are some of those expectations that you like to go over with patients and their families?
Um, well, we do talk about that we don't know whether their child will need to be on this medication forever. We know that in research studies, when medications were stopped, people gained weight. Um, but that said, I also have had plenty of patients who could come off of it. And I think it sort of depends on where they were to start. So if they had a lot of improvement to make in their diet and activity and they made major changes, those patients might do okay. Or if they lost access, like, for example, maybe they lost access to medication for cost or whatever reason, they've established a different lifestyle that they're able to sustain without medications. But they could need that medication, for their lifetime, which is, what I tell them is what Dr. Francavilla used to say, whatever you do to lose weight is what you have to continue to do to keep it off. So, so that goes with medications and with sort of lifestyle changes. So whenever we're trying to decide on, some probably some tiny little thing like, are you, walking 5,000 steps a day or something like that? I'll tell them, don't tell me you're going to do this if you don't think you can continue doing this, forever. So it makes it easier to sort of make those set those goals as well. So, the expectation is that yes, they might need it forever, maybe they don't. I'm hopeful that maybe a pediatric brain or a developing brain, maybe they could be reset, with earlier intervention. And I definitely have seen that in a few of my patients, but I don't know what the research which shows on that. I don't think that's a really hard thing to track.
Mhm. Yeah, and I agree, and it can be hard to predict, but something that I've seen in my practice is the earlier on in the disease course, and any disease that we're talking about, and today we're talking about obesity. So earlier on in that trajectory that we intervene, then the better outcomes that we're going to see. And
Mhm.
the more likely that somebody is to maybe be able to wean off of a medication if that's what we're using, and then have sustainable results. And so that's what I've seen with my adult patients, or young adult patients
Mhm.
specifically. And I think that that's one of the I guess, arguments for treating weight in the pediatric population because it can have such a profound impact to later on as adults. So I don't know if that's kind of what you were taught in your training or that's what you've experienced as well.
That's, yeah, definitely what I've experienced, and I definitely have many of my patients come to me with parents who also have obesity, and they say, "I don't want my child to go through what I went through," and that's why they want to intervene earlier as well.
Yeah.
So, yeah, I would agree. And recently there was a study that was published out of Sweden where they were um, following children with obesity into adulthood, maybe into age 30 or so, and they classified them in two groups. So, obesity, but sort of healthy, meaning normal labs, normal blood pressure, and then obesity with some complication like abnormal labs or blood pressure. And they followed them into adulthood to see what is their risk of developing diabetes or other, high cholesterol, weight related conditions. And they found that the children with obesity who had sort of unhealthy obesity, you could say, had a much higher risk of developing these conditions. But also the children who had obesity but did not show any complications, they also had a higher risk, not as high as a risk. So just, yeah, so the reset, I think, at an early age is very reasonable and a good reason to intervene sooner.
Yeah, thanks for sharing that. Um, so we've mentioned parents a few times throughout this talk. Obviously, they play a very important role in pediatric care. So, what if there was one thing that you wish every parent would know? What would you want to share with them?
Basically, that it's not their fault. As parents, particularly mothers, we tend to blame ourselves with anything that goes not quite as we would like with our children. And so it's really not their fault because of what our environment is like now and how stressful life is and how much more stress their children are under than probably they went through as children. So yeah, definitely that it's not your fault and that I understand what they're going through. That seems to bring parents puts them at ease when I see them in the office. You can kind of see the tension leave their body when they realize they're not being shamed and blamed for what's going on.
Yeah, yeah, that compassion goes so far. So I'm glad that you have that approach not only with your patients but also their families. So
Mhm.
that's wonderful to hear.
Yeah.
Um, Anything that you think we missed that would be important for viewers to be aware of when it comes to pediatric obesity?
Yeah, I think a few things. One is I think expectations when they come in to see me. I think they are worried or concerned that they're going to come in and I'm going to give them a weight goal and a calorie counting plan and a very specific guideline of what they need to do. And it's not like that at all. I don't set weight goals. In fact, I barely even talk about weight or the number on the scale. We talk about it more in terms of health, of being, quote, healthy on the inside, feeling good in your body, feeling good about yourself, having a healthy relationship with food. That's more of our goal. So I definitely don't feel the need to bring patients into, you know, a middle of the road BMI. We really are looking to just find what's right for them. So I think that's what people don't expect that when they're coming in. I think that they're nervous that they're going to get a very regimented um, approach, and it's really going to be very individualized to their kid.
Yeah. Yeah, I think that's great. Well, thank you so much for taking the time out of your busy schedule. You're doing such important work.
Thank you.
If anyone was wanting to find you, maybe, bring their child to become a patient, where should they go?
They can go to evoraforkids.com, evoraforkids.com. We have also an Instagram and a Facebook page under the same name. They can go on there. They can self-schedule a 15-minute visit with me just to talk about whether we are the right fit for one another. And if we're not the right fit, I might just help direct them to what they do need. So that's really the best way to do it. I have a blog that I post on my website as well, which really talks a lot about my approach and some of the topics that come up in my visits, pretty frequently. So when I have the same conversation over and over again, I think I should write a blog on this. And so then I do and post it up on there. So that's a good place to get good information as well.
That's a great resource. I will make sure to include all of those links in the show notes below so anyone can easily find you. But yeah, thank you so much again. And hopefully I'll have you on in the future to talk more about this important topic.
Sure, I'd love to. All right. Thanks, Lindsay.